In the fourth part, we are going to discuss both neutrophils defect and complement defect as a causes of sinopulmonary infections. Let's start. You know that neutrophils defect is divided into two problems. First problem is neutropenia, which is count defect that possible to be transient, cyclic or permanent. Neutropenia is defined as absolute neutrophil count of less than 1500 per cubic millimeters. The other problem is functional defect occurs when neutrophils lose either its chemotaxis function or its intracellular killing power. Before starting to dig deep in neutrophils defect, I would like to remind you with some keynotes from the introduction video or part 1. Remember that neutrophils love to abscess everywhere. Moreover, neutrophils love to ulcer every mouth too. Neutrophils are close friend to Staphylococcus aureus. Antibiotics, especially into Staphylococcus penicillin, that we talked about in the snack video, should be ready. I am going to put link to penicillin snack in the comments below. Last point is that granulocyte colony stimulating factor is the best way to force neutrophils production. Let's start with transient neutropenia. It's defined as neutropenia that persists less than 3 months. It's caused by many external factors. Causes include viral infection, which is most common cause, adenovirus, Coxsackie virus, cytomegalovirus, EBV, respiratory syncytial virus, hepatitis A and B, measles, influenza, rubella, and varicella. Neutropenia usually develops during the first 2 days of illness and may persist for up to a week. In general, patients are otherwise healthy and are at low risk for serious infectious complications. Second cause is bacterial sepsis and endotoxin suppression. Other causes are there, for example drugs, neonatal alloimmune, secondary to maternal IgG directed against fetal neutrophils, and autoimmune, for example, autoimmune neutropenia of childhood, systemic lupus erythematosus, Evans syndrome. Other causes are hyperinsulinism, metabolic factors, for example hyperglycemia, isovaleric acidemia, propionic acidemia, methylmalonic acidemia, glycogen storage disease type 1b. Nutritional deficiencies also may cause transient neutropenia, for example anorexia nervosa, marasmus, B12/folate deficiency, copper deficiency. Finally, a malignancy is one of the important causes of neutropenia, especially leukemia and myelofibrosis. There is one exception to the rule of 3 months. It is autoimmune neutropenia of infancy. It is most common form of transient but chronic childhood neutropenia. This disorder displays a ratio of 3:2 female predominance. It is caused by a chronic depletion of mature neutrophils. About 90% of all cases are detected within the first 14 months of life. The median duration of neutropenia is 20 months, and 95% of patients with this condition have fully recovered by the time they are 4 years old. The neutrophils in case of autoimmune neutropenia of infancy is usually below 500 per cubic millimeters, and the bone marrow displays normal cells, despite an arrest at late stages of metmyelocytes or at the band stage. Anti-neutrophil antibodies are occasionally detected, but their presence is not necessary for the diagnosis of any. In case of cyclic neutropenia, patients recurrently become neutropenic for 3 to 6 days over a 21-day cycle, range from 14 days to 36 days. Clinical picture: follow the general picture of neutrophils defect that we talked about, but cyclic not continuous. The condition is autosomal dominant and has been linked to elastase gene mutation. Treatment also follow the same rule as mentioned in part 1. Congenital neutropenia, occur due to failure of differentiation and maturation of the myeloid lineage. Commonly presents in the first year of life with Staphylococcus infection everywhere. Skin abscess, stomatitis, osteomyelitis, meningitis and septicemia. Diagnosis: follow step 1 only will be enough to reach to the diagnosis. It will reveal persistent neutropenia less than 0.5 times 109 per liter over a 3-month period. To confirm the diagnosis, you need bone marrow examination that will reveal maturation arrest of myelopoiesis at the level of promyelocyte/myelocyte stage. Genetic testing may be needed if diagnosis still in doubt. Treatment: again, follow the rule mentioned in Part 1. Aggressive treatment with anti-Staphylococcus. Most patients respond to granulocyte colony stimulating factor. Long-term risk of developing myelodysplastic syndromes and leukemia. Hematopoietic stem cell transplant is considered for patients with granulocyte colony stimulating factor refractoriness, cytogenetic abnormality in bone marrow or frank malignant transformation. There's other type of congenital neutropenia that is associated with exocrine pancreatic affection. It is called Schwanman diamond syndrome. It is a combination of mentioned manifestation of congenital neutropenia, in addition to pancreatic exocrine insufficiency and skeletal abnormalities. Most patients have neutropenia, and up to 25% may develop pancytopenia. The risks of myelodysplasia and leukemia are increased. Diagnosis and treatment are the same as congenital neutropenia. Also, you will need to investigate pancreatic exocrine function and skeletal involvement if present. For the exam purpose, it is also wise to know that hematopoietic stem cell transplant may be curative. Leukocyte adhesion deficiency. There is no problem with neutrophils count, but rather, we will find defective binding of circulatory neutrophils to vascular endothelium. There are 3 forms of leukocyte adhesion deficiency. Type 1, being the most common, which is an autosomal recessive defect of delta-2 integrin adhesion molecules CD18 on neutrophils, resulting in defective aggregation and apodoxical leukocytosis. Classic presentation for type 1 is delayed separation of umbilical cord beyond 3 weeks, poor wound healing, often without pus. Periodontitis and recurrent or genital infections may occur. Don't forget that neutrophils love the mouth too. Leukocyte adhesion deficiency type 2 is also autosomal recessive. The primary defect in a specific GDP-L-fucose transporter of the Golgi apparatus. Patient usually has the same picture in addition to typical dysmorphism, psychomotor retardation and the Bombay blood group, growth and developmental retardation. Leukocyte adhesion deficiency type 3 include thrombocytopenia, in addition to manifestations of type 1. Pathogens include, of course, Staphylococcus aureus, in addition to Aspergillus, Candida species, and gram-negative enteric bacteria. Investigations. Step 1 that will reveal leukocytosis and neutrophilia that may reach up to 100 times 109 per liter in acute infections. Leukocyte adhesion deficiency type 1 will need more sophisticated investigations that will show abnormal CD11/CD18 complex expression on neutrophils by flow cytometry. Genetic testing may detect ITGB2 mutation. Management-wise, should include prophylactic antibiotics and early treatment of infections. Hematopoietic stem cell transplant should be considered for severe disease which otherwise results in early death. Before moving to next disease, let me briefly tell you about Bombay blood group. It is also called H/H blood group or O blood group. Individuals with the rare Bombay phenotype HH do not express H antigen, also called substance H, the antigen which is present in blood group O. As a result, they cannot make A antigen, also called substance A. Moreover, they can't make B antigen, or also called substance B, on their red blood cells, whatever alleles they may have of the A and B blood group genes, because A antigen and B antigen are made from H antigen. For this reason, people who have B phenotype can donate red blood cells to any member of the ABO blood group system unless some other blood factor gene, such as Rh, is incompatible, but they cannot receive blood from any member of the ABO blood group system, which always contains one or more of A, B or H antigens, but only from other people who have B phenotype. Receiving blood which contains an antigen, which has never been in the patient's own blood, causes an immune reaction, due to the immune system of a hypothetical receiver producing immunoglobulins, not only against antigen A and B, but also against H antigen. The most common immunoglobulins synthesized are IgM and IgG, and this seems to have a very important role in the low frequency of hemolytic disease of the newborn among non-Bombay offspring of Bombay mothers. Chronic granulomatous disease is a disorder of impaired intracellular killing of pathogens in hyperinflammatory state. The molecular mechanisms responsible for this disease are heterogeneous because any defect of the 4 subunits that constitute the NADPH oxidase can cause chronic granulomatous disease. As a consequence, superoxide, oxygen radicals, and peroxide production are lacking, and patients with chronic granulomatous disease cannot kill catalase-positive pathogenic bacteria and fungi. Impaired hydrogen peroxide generation and oxidative burst caused by genetic defects of FOX protein subunits constituting the phagocytic effect of NADPH oxidase. The X-linked form of chronic granulomatous disease, GP91 FOX deficiency, accounts for 2/3 of cases and usually presents earlier and with more severe disease than autosomal recessive forms, P47 FOX, P22 FOX, P67 FOX, and P40 FOX deficiencies. Clinical picture resembles that of any neutrophils defect, in addition to faltering growth, suppurative adenitis, hyperinflammatory state in the form of inflammatory bowel disease, granulomatous lesions, and lymphadenopathy, which may result in intrathoracic, gastrointestinal or urinary obstruction. Investigations. In addition to step 1 as mentioned in part 1, nitroblue-tetrazolium/dihydrorhodamine test, that indicate failure to generate reactive oxygen superoxide during the respiratory burst. Immunoblot, or flow cytometric analysis of FOX proteins. Mutation analysis. Management. In addition to management rule previously mentioned, prophylactic antibiotics and antifungals are needed. Steroids to treat granulomatous disease. Aggressive use of antifungal agents and granulocyte infusions along with interferon gamma may be required to manage severe fungal infections. Hematopoietic stem cell transplant offers good chance of cure, especially in patients with matched sibling donor. Defect will be deferred to part 6 or 7, as I found 8 more suitable to be discussed with angioedema. And now, the time has come to say goodbye.